I'm good, my love. How are you?
Did you get all the pets done this in time this morning?
I think so. I think so. Good grief. I was just like, my computer decided that it was going to update, and it's like, ho hum, ho hum, ho hum, ho hum. And I'm like, not now, not now.
We're not in a hurry. Kirsty sees a lot of patients. So and a lot of crazy patients. She doesn't get very many normal patients.
No,
Um,
they stopped sending me the usual stuff ages ago. And
oh,
if you work with Matt Brunke, then you get the weird. You definitely get the weird.
I have lots of questions though.
Oh, heaven help us. Okay, yes. What?
Well, we
It's
can
good
say
to see you again. I have to say, it's good to see you again.
well, so I'm like coming up with all these questions. So I made a list.
Oh, you could have sent the list ahead of time.
No, that wouldn't have been any fun.
Oh no, let's just put Kirsty on the spot, shall we?
I'm learning. I'm getting there. I actually am like starting to find the trigger points myself without people showing them to me. So
That's awesome. That's half of the battle is, the one thing you can't teach people. And I wish there was is there's no way for me to tell you what these are feeling. I know what they're feeling because they're attached to me, but it's so hard
I
to,
know.
to teach that to somebody else.
And
And
that's the hardest thing we run into with training too, right? Because
yes,
um,
yes,
what
it's really difficult. And I think the more you do it, but once you have like that aha moment and the little light bulb goes on and you're like, is it? Is it? And you're like, ah, and then everything is like the last little piece of the puzzle that goes in, and then the picture makes sense. And then you find like 60 million. You won't help. It's like buses. You see a yellow bus and then you don't see a yellow bus, and then you see a whole bunch of yellow buses. You'll all of a sudden your fingers recognize what that tissue feels like, and you're off and running.
well, it I what I find out in the world is people get timid about what they feel and believing what they feel and believing the machine is doing what we expect it to do. So that's just for me. That's just using it and
It
understand.
is. My granny was a good one for saying, the proof in the pudding is in the eating. And, I mean, is it a trigger point? Okay, well, let's treat and find out.
So
You
then that
know,
how do you know what it is? So that is one of my questions. So we have had a few more people jumping in, but I think it's not how do you know what it is? How do you know it's a trigger point versus compensatory type muscle that you don't want to release because they need it? You know what I mean?
yeah, I mean, I think that's the biggest conundrum, as body workers in general, we have that problem. You have to, and I mean, this is, when you start doing myofascial work, when you start doing like massage therapy, you have to look at the whole patient. You have to know and understand what is compensation, but what's causing the primary problem? What is our primary problem? Do we have hip issues, elbow issues? Do we have stifle issues? Is it, long term? Is it chronic? Is it acute? Is it a post-surgical case? What have we got as far as like leg length inequality, and what is that doing to the rest of the body? Once you kind of understand what is like compensatory muscle tension, and I mean, compensatory muscle tension can come up anywhere and any region and for any reason. I mean, we're veterinary professionals, and if you're anything like me, I'm as clumsy as all get out, and I'll fall over thin air if it's left out for me. So, I'll stab my toe. 2 days later, I'm like, why is my back so sore? Because subconsciously I've been holding myself differently because I hurt my foot or I hurt my knee, or, I whacked it getting up on something. If I've tweaked my shoulder, my neck and my lower back, everything compensates. And it's subtle, and you don't realize, you don't consciously wake up and say, hey, I'm going to walk awkwardly for the next 2 days. Let's see how that works out. So our poor pets, they have, yes, like a TP standard cruciate, TPLO, whatever you're going to do to your stifle, at the time of injury, the compensation starts already. So what's happening to the opposite hind leg? And then what happens if, everybody is crazy, crazy busy these days? So getting in for a TPLO isn't like this immediate thing anymore. There's a couple of weeks to a month's wait. You've got all of that muscle compensation happening. You've got muscle atrophy happening just through disuse. You've got that leg length inequality happening. And then you're looking towards like your lat dorsi, your triceps, you've got, your trapezius, your deltoids, all those start to suffer as well. And when you're looking at big bodies of tissue, you're looking at compensatory tension being, the muscle kind of will feel very tight. Muscle should have tension in it, but not such an amount of tension that if you kind of palpate it, you feel like the muscle's being like, no, bugger off, get out, go away. And your fingers but the body will actually kick you away and kind of kick you out because the tension in that muscle is too bad. So you can assess tissue that way, and then you're going to look at the play of the fibers. We look a lot, we see compensation, especially compensatory muscle patterns will come up as a lot of banding. And that'll basically feel like my best analogy for this is if, you get a packet of uncooked spaghetti and kind of roll it out across the countertop and then run your fingers over the top of it. It's those little myofibrils contracting in a complete line and unevenly, and it'll feel like little like little tiny rib speed bumps, and that's banding. And when we look at myofascial, like the trigger points, you're feeling is a deeper palpation, and it's a specific point. It's very unusual to come across a myofascial trigger point in an entire muscle. I mean, that would be really bad. Could you imagine having it be like the worst trigger point of the worst trigger points? I mean, no linear probe will get rid of that. So, you gotta, sometimes you have to get rid of the compensatory tension with whatever methods you're working with, whether it be your manual therapy, your instrument assisted manual therapy, using the piezo wave, to kind of get through some of that tension, and then reassessing the muscle as you go along. You can't just like whack at it and be like, Yahoo, job done. It's a constant balance of, test, treat, repeat, test, treat, repeat. Yeah, you've got to assess if your techniques, whatever techniques you're using, are being effective, because if they're not being effective, then you're like, okay, we need to stop, we need to move on. Let's try heat massage. Your fingers are the best tools you have. Start with that. And then, you go deeper and deeper and deeper and deeper.
So does anybody have any specific questions?
Other than everybody on this forum should be, if they don't have one, they need to purchase one. And if you have the focal probe, then everybody needs a linear probe. We just got our linear probes, and it's changed my game on my myofascial stuff like tenfold just again. So all of my cases that were doing really well with my focal probe, they're now doing exceptionally well with my linear probe. So yes, so everybody should have a machine, had focal and had the linear probe as well. How many of you are doing any of the myofascial work? Who's in rehab? What does everybody do?
I know Chelsea is a equine practitioner.
Yes, I do a PEMF and ESWT on horses and people and dogs.
Yep.
Awesome. Hi, Chelsea. You're a lot braver than me. Horses scare the jinkiness out of me. So I'll stick to my cats and dogs, but you have my respect for treating the horses, because I know that being the ligamentous beasties that they are, they really dig the ESWAT. They really dig the ESWAT.
They do. And I've really enjoyed pairing it with the PEMF. I wanted to, when I got the piezo wave, I wanted to see what it did absolutely naked at first, because I was encouraged to pair it with the PEMF right away, and I didn't like that idea. Mm-hmm. And it does, just like in people, it can cause a little bit of soreness after you do the work. And the really cool thing about pairing it up with the PEMF is the high power PEMF eliminates that after shockwave soreness. So that's been really cool to see, because I would work on a horse for the first time and they would really be into it and they would love it. And it was great. We had a great session. The owner's happy, everybody's high-fiving. And then a week later, I would show up and the horse was a little terrified of me. And it was pooping and it was worried, and it was because I caused this soreness. And I went, okay. So with some horses, like my mare, that's the picture of her, she completely understands all of the equipment and what I do with it. And so I don't have to ask for forgiveness with an EMF with that mare. And some horses I do not. Some horses are like, no, it's okay, Chelsea, I get it. You made me sore, but it made me feel better. And others, especially if it's the first time I've ever worked with the animal, I almost have to do the PEMF or with the horse. Dogs, not so much. But with the horses, if I got to ask a little bit of forgiveness first with it, or I would have to sedate them, which isn't legal for me.
Just out of curiosity, with what do you start with a set amount of hertz and intensity, or do you start off low and then kind of ramp those up and adjust your treatment times and your treatment parameters according to the response of the animal and the tissue?
I start at 3 pulses a second at a very low intensity and see how the horse reacts. One of the best tips that Cindy ever gave me for my my therapy source was to hit 2 buttons on the machine to make it go to 0.1, 0.2. And so I start there quite often. And I always feel like I must be doing a better job if I'm working at a low intensity and I'm getting good responses from the animal. So I never try to, if they're looking at me and I'm at 0.3, and if I go up to 0.5 and their eyes get a little wide, all I need to be at is 0.3 because they feel it, there's something happening in their body. I don't need to overpower it. And I get great results at really low intensities. As long as they're responding to me, I can drop that human urge to make it go faster and stronger. But once I do that spot, I go up to my maximum pulses per second just so I can get the job done faster. So I can do, 500 pulses in a reasonable amount of time in that area.
Perfect. I think that's a big key thing is making sure that you're not just trying to get through the treatment and like blasting through it and creating more discomfort than and I have to say, since working with Cindy and working with the machine and working with the myofascial stuff, I'm finding that my intensities and my hertz and my pulses per second are so much lower. Because it's the same like with anesthesia, you're dosing to effect rather than just kind of like, okay, we've got to get this done. I've only got like 20 minutes. We've got 2,000 pulses that we've got to get done. And, we're going to jack it up to 8 and make the dog jump. But, so I found that, having, especially doing a lot of the myofascial stuff, because we're a little bit more superficial. We've got some of the deeper muscles. But if I'm working on a deeper muscle, then I'll bang out definitely the linear probe for those. So that's been super. The linear probe has been super helpful for getting to like the slightly deeper the slightly deeper like trigger points and myofascial tender points, especially like some of the like paraspinals, some of those nice big hip flexors, great for like psoas work, absolutely in a class of its own for psoas work.
And it's a little, I like it because it's a little lazier of a probe too. Like you don't have to be quite so accurate with that one,
It's the lazy man's probe. Hey, there you go, Cindy, new marketing ploy. Lazy man's probe. I like it.
It's like learning how to ride in a Western saddle versus an English saddle. Don't do it. You want to learn how to ride English and then you get in a Western saddle. Don't do it the other way around.
It's like finding a vein in a horse before you learn to find it in a cat.
Yes, exactly.
Yes. And obviously these are very species dependent. Yes, I have not come across a cat yet that would tolerate my linear probe, no, but definitely. But I mean, it's nice because Cindy brings up cats. We've got, how many things can we use to effectively help with long-term chronic, osteoarthritic and body change postures in our cats. I mean, diddly squat. They dig it, like everything, they dig it. And cats, I mean, yes, I'm a cat person. I'm really sorry. Cats are aliens, but cats get it. Cats are really smart. They know what helps them and they know what doesn't. And they're not ashamed to say, you know what? You're not helping me at all. I'm going to remove myself from the situation. But if you've got the right spot, and I had one of our employees had a 16-year-old cat with bridging spondylosis and LS issues. And she'd stopped grooming herself. She'd taken to not jumping up on vertical surfaces like she used to, and we shockwaved her. And we did like 4 or 5 treatments over a course of like 8 weeks, and she's been great. She's able to groom herself better. Her comfort is better. She's not, the biggest change was she stopped missing in the litter box. And I mean, how many of these inappropriate urinations and defecations in and out of the litter box are, joint and back issues with our older cats.
So you mentioned depth. So that was another one on my list of questions.
I wish there was a depth chart. I almost want to print out my own little millimeter, like just a little tool that I can have so I can hold it up to the animal's body, and then I can guesstimate it. But I just use my general rule of thumb is start shallow, work deep.
When we consider myofascial trigger points, are those really just the ones we can palpate with our hand, unless we're not going to be that deep when treating those? Or does that include deeper gluteal trigger points? Or like how do I?
You can have this, just chocolate.
I think you've got to look at the whole thing. You can have layers. You can have these layers. You've got layers of muscle. You've got superficial, you've got deep. Sometimes you think that the trigger point feels a lot deeper because you're trying to get through muscle that needs treatment before you can figure out what's going on underneath. So it's like peeling away the layers of an onion. You're gonna check very, very superficially. I mean, the skin should play very, very nicely over the tissue. If there's any kind of fascial tightness, you're gonna see a change in the movement of the actual skin. You should be able to get your hands and kind of move over the skin, and it should be like a glove on a glove, and everything should move underneath each other. What I've been seeing typically recently is, if there's areas of like, tightening or fascial tightening, usually right under a real thumper of a trigger point, the fascia will reach up under the skin and kind of go weep, and it'll kind of pull it down. So you'll see little changes in like hair coat, like, so that the body is trying to tell you and say, look, treat here, hi, this is where there's a problem. So, getting your fingers just over the skin first, treating some of those, seeing what comes out, and go a little bit deeper, check your range of motion, look at how the dog is looking at you. Does that feel okay? Are they leaning into you as you kind of move through your tissues? And then you get a little bit deeper and deeper, and you're going to feel like, tension, banding. You might just feel like it might feel like a brick of concrete, and you could have like 2 or 3 trigger points under there, but you got to deal with the concrete first, because you're not going to feel those trigger points until you deal with the concrete. So, finding the right tools, which I think it becomes multimodal. I mean, we talk about multimodal approachment to just about everything these days, like pain management, arthritis care, joint care, myofascial care, shouldn't be any different. So, it's a great thing to have so many things in this little toolkit that we carry with us, that we can start with our fingers, and then we can go to our heat packs, and then we have our instruments that we can use. And then, we've got our lasers. Those of you that are able to needle for myofascial, that's invaluable. As a technician, my state, which is Virginia, I'm not, can't use the needles. So what does that leave us with? We've got our laser, we've got our piezo wave, and I will jump to my piezo wave, and I can laser or PEMF afterwards if I feel that the treatment, especially if it's a really tough muscle, then you're always going to have like a little bit of soreness. Well, it's like if you've ever had a deep tissue massage, you feel and move a lot better, but someone feels like you've been beaten up a little bit, because you're trying to get those muscle fibers working again. You're trying to get that cellular metabolism back in. You're getting rid of those nasty cellular metabolites. So you need to be really, really careful with your older dogs that you don't overdo it and flood the circulatory system with too much of those endorphins. So taking it nice and easy, start shallow, work through deep, but pay attention to what's happening within the body, making sure that that big muscle that you really want to get down there and kind of get in and get all that treated isn't the one thing that's stopping the dog from turning into a four-legged puddle. So, your hip dogs, your iliocostalis, your quadratus lumborum, whatever you want to call them, your longissimus, your lat dorsi, those are going to be stabilizers. They're also going to be movers with that, with that very traditional swagger that we see. So you have to kind of be really careful treating those muscles, because you don't want to cause any knock-on effects and kind of destabilize what may be some sort of a normal gait for that dog. So yeah.
When you said puddle, you don't want to turn them into a puddle. Is that where you see some after treatment soreness?
Yes. Yeah, definitely. So you you don't want to have your patient, I mean, not so much with your horses, but you especially for the dogs, the older dogs, you don't want to have you see them walking in, especially the multi-joint arthritis ones. So we're like, okay, so we want to treat the joints, but we also want to treat our soft tissue compensatory trigger points, because there's going to be loads. And then the dog is so going to be like, okay, I'm so floppy now that you're going to have to carry me out on a gurney. And I never like to be the person that has to take the dog out and be like, sorry, give it a couple of days, it should be fine. So you need to almost pick your poison, find out what can you fix, but also what is going to come back. Trigger point therapy is so satisfying because you can improve functional biomechanics in such an effective way. But if you've got chronic disease that you're not gonna you can't fix, like really nasty arthritis, you only manage the symptoms as a result of the disease itself. So you can go to town on your trapezius, on your triceps, your biceps, your neck, work on everything. The dog's going to stand up and walk out and look fantastic, and then probably 4 or 5 days later it's going to go back to being the way it was, because you've helped it in the interim, but some of these trigger points are going to constantly reoccur because of the chronicity and the chronic nature of the actual joint disease itself. So, you've got to think of some of these myofascial things as a very long-term project. You can get them to feel better, through several treatments. You can probably get some of the compensation to be less dramatic. But some of these trigger points are going to be sort of, sometimes lifelong treatments, because the disease itself is going to be ever present. So pick your battles.
Pick your battles carefully.
Carefully pick your battles. Yes.
So I had a very interesting conversation in Colorado with Dr. Reichel, I believe it was, Dr. Jess at Red Sage, because I always treat my joints and my arthritic joints and stuff for, like pain management, anti-inflammatory. And she was discussing a study that she did when she was at CSU, where 6 months later was when they feel they were actually getting the most effect on both the chondroprotective and the subchondral bone. And I was like, wow, because just because of my role as, demoing and showing people things, I never really went to the fact that, hey, these 3 treatments are going to affect your joint health in 6 months. I
Yeah.
thought that was interesting.
Yeah. Well, you're stimulating, if you could do like a real time like arthroscopy and have some sort of like tissue sampling, so you could find out, the difference between, the effect of your treatment immediately, like what is that treatment doing to the bone and to the tissue, like right at this minute, and what are we stimulating, what are we waking up, what are we kind of saying, like, yoo-hoo, time to get to work, and you've started like a cycle of repair that is compounded with each treatment, but it's the building block of something that is going to start to kick in and appear more beneficial, further on in the future, whether it be 3, 6, or 12 months. So, in myofascial care, it's the same thing. You're still going to help in the interim, but these sorts of things, when we look, especially with long-term chronic orthopedic disease, that's long-term lifetime maintenance care. So having all of these nice tools that you can use, yes, laser's going to work for a while, and then laser may not be as effective, and then you're like, okay, well, we've got joint inflammation under control, we're on our chondroprotectants, everything else, what else is it that we can do to help, because they still get up a little bit stiffly, we look at
They still do. What about us?
oh yeah, I mean, crikey, I have to say, I like to make sure that, I feel the benefit. Like, I like to try a treatment on myself, like what hurts, what doesn't hurt, does it feel uncomfortable, does it feel weird? Because, you want to try and explain that to the client, this is what they may feel, and going through, like, I was part of the very early CCRP class, very early. And we had to do e-stim, and we had to, you had to do e-stim incorrectly. Like, you had to turn it up because you had to understand that you were creating a contraction in a muscle. And if you did it too hard and a little bit too gung-ho about it, it's going to hurt like a stink. And it did. It hurt a lot. So, I had some discomfort in my shoulder. So I was like, okay, let's see what this new machine can do. So I got my probe out and I was like, talkie. And I was like, oh, yeah, okay. And then so I did my treatment and I was like, okay, I may back on that a bit. I may increase that a little bit. And I was like, holy cow, what happened? So, and I did a couple of treatments on my shoulder, and they were going to inject steroids into my shoulder. And I went back to my orthopedist like 6 weeks later, and he's like, so when are we doing that? And I'm like, we're not. And I'm like, look. And he's like, what did you do? And I'm like, I did shockwave. And he had no clue. And he was an orthopedic surgeon, a human orthopedic surgeon. And I'm like, how do you not? You just want to stick needles and cut things. Like, this works. It's non-invasive and it's tolerable and it's helpful. And I saw long-term effects.
But I mean, obviously, when we train and at all the courses, we want you guys to feel it, but it's you putting it on yourself, so that makes it and you're not charging for it and all that stuff.
No.
But
has anybody used their piezo wave on like a really cool case that they've seen like a good improvement with?
I've fixed or avoided surgery on 3 horses with upper fixation of the patella
Awesome.
in
Awesome.
2 to 3 sessions.
That's awesome. That's awesome.
PMF can't do anything for that. Shockwave blows it out of the water.
Without a doubt. Without a doubt. Anybody else done anything cool? Anybody used it on like any exotics?
I haven't used it on exotics, but I did have a lab that I had used it on as a trial, and we weren't sure that we saw any results. He had severe end-stage hip dysplasia. So we gave up. We did like 3 or 4 rounds, and we're like, all right, whatever. And then he went to his primary care vet or the surgeon like 4 months later, and they recommended euthanasia. And I said,
Yeah.
well, I was like, well, let's just try that Pisa wave one more time, because who knows, maybe that was a thing. And that was literally the thing that got that dog walking again. And I could treat him every 4 months. He was probably the longest spacing patient that I could have, but that was pretty awesome.
That's awesome. I mean,
And what-
sometimes you just have to circle round and, try it again.
rinse, repeat. So did you
Yeah.
change anything between, the original therapy and when he came back?
I don't think so. I think I just did I repeated the one treatment. I think it was just hard at the time to know if what was helping, and he was doing okay, but then he'd gotten significantly worse. So I think the treatments had worn off.
Yeah.
And he'd hurt himself, and it was just perfect timing, but we could almost clockwork it. So I think we set it at 3 months just to get it before he got worse.
Yeah.
But he was a pretty consistent 3 month, and that's all he needed was a shockwave treatment.
And are you shock waving just the hip joint, or are you doing the musculature around it?
For him, we just did the hip joint.
Interesting. Isn't that
That's
amazing?
awesome.
Yeah,
That's awesome.
That's amazing. When you're working on those joints, the actual bone and cartilage changes takes a long time for them to settle in, and that's probably why you're getting such a long, span in between. So that's cool. I have to say, when I do hips, because of some of the, I guess Dr. Struble or a few people, I often do the hip, at least the hip flexors, because usually I feel they don't have good extension because of the hip flexors.
So when you do that, what's your protocol? Do you do like around the joint for like 500 shocks for 3 points and then scan the hip flexors, or do you just scan the whole thing?
So again, it depends on your purpose, but yeah, I would go into the hip joint I usually do 2 points, being careful of that kind of lip over the caudal side of the hip joint, which is hard to get the energy in that area. So I tend to do 2 or 3 points if I'm just trying to get into the hip joint. But I've started lately to move all the way to be a little shallower and move through the whole circle around the acetabulum, and to get into the hip joint from that to basically attack the capsule. Does that make sense? And not just the joint fluid. So again, are you attacking the subchondral bone and cartilage? Are you attacking the joint fluid? Are you attacking the capsulitis? So I've started to do a lot more on my joints a little shallow to get the capsulitis. But if you're getting success with that dog in a few points going directly into the joint, you're obviously doing good. Then for the muscle, I do kind of scan through that muscle right in front of the hip, and also really do some passive range of motion. That's what I do.
So for like a lab size, would you do a depth of 10 or a depth of 5 if you're doing the soft tissue around in that capsule?
I mean, if it wasn't overweight, and it was decently muscled, I'd say a 10.
Yeah.
Certainly nothing deeper than a 15. And then, you could use that to scan through those, the surrounding, hip flexors as well. I mean, if you're in any doubt, so some of those little hip flexors, they tend to be kind of a little weedy, the glutes tend to be like non-existent. You can swap the heads out, do a 10 for the capsule and then swap out to a 5. But, I mean, the linear probe really comes into its own for doing, for scanning for muscle, like doing the whole muscle. You can get a nice wider breadth of treatment. It's great. Love it.
It was a fight to get that linear probe for those 2 hospitals.
But we got them, and we've been using them, and it's awesome.
I think Deanne, it's just a matter of every once in a while, I think we have to stop and I have to make myself, after some of my training sessions, stop, feel the tissue part way through, move the joint part way through, and decide, does it need more? Does it need less?
Yes.
That type of thing. And I think too often we look at whatever we've been using as a protocol and we set it to 1,000 or 500 or whatever, and we just go because we're in a hurry and, you know,
yeah.
Yeah, it's hard because my staff does the treatment. So I write the protocol, but then it's hard for me to check back in. So it's almost like I would have to schedule a couple of them for myself just to play with the settings and whatnot.
But when I come in to help people with their training, is to empower the technicians enough to be able to make small changes, not huge changes in the protocol, but to make minor changes as to what they feel and see for that particular day. You know, and not feel like they absolutely have to follow the exact numbers, because every day is different for every animal. You know?
Yeah. Especially if they're having like an acute on chronic flare, you know, you might want to back down on your intensity, you know, the number of pulses that you use, you know, there are so many different ways. And I think, you know, as Cindy said, you know, you got your protocol book, they're guidelines, you know, they're really good guidelines, but you have to look at the patient as an individual. You know, I mean, what works for one hip is not necessarily going to work for another hip. So, you know, you look and treat what is in front of you. You know, one day you may have like the 120-pound Rottie, you know, the following day you may have like that cute little lab with a BCS of 5 that, you know, has bad hips, you know. So you've really got to look at your patient, get your hands on your patient. I mean, whether you do like anything that we do, we use our hands, our tactile sensory organs right here. They tell you so much. You know, you feel the tissue. Does it feel hot? Does it feel warm? You know, does it feel super tight? You know, how is the range of motion? You know, we're using all those things to determine, like, you know, what we're going to use to set, you know, to set the machine at. But, you know, if I'm working with, one thing I have done is if I'm working with really tight muscle, then, you know, I'll do 2,000 to 2,500 shocks. I'll turn the hertz and the frequency, I'll turn everything down nice and low, and I'll do like a longer, lower, less intense treatment. And then midway through, I'll reassess. Because sometimes, you know, that tissue it's so tight that if you go at it like with a gangbuster, you know, you can trigger those pain responses. You can see that, you know, you can see the reaction in the dog. Whereas coming at it kind of low and gentle and having, you know, a longer treatment helps me personally, has helped my patients much better. They settle into it better. And I can get sort of more of that finer definition coming through the tissue as I work through it, because it's working through those superficial, and then we can go down to the deeper, and I'm not having to stop and reposition and reassess. I can kind of just reassess as I go along, and then just keep going with the same treatment without having to reposition the patient. So.
And Deanne, are you able to schedule, it's always hospital by hospital, but are you able to schedule so that the same technician can save the same pet, or is it always different?
It depends on the client. The one that I'm thinking of right now, he comes at 8 a.m. like the exact day of the week. So it's oftentimes 1 or 2 therapists, but I may just see if I'm not scheduled, I can pop back in and we can talk about like tweaking or anything like that. Because I think he has a checkup coming up next week anyway. So it's perfect timing.
I encourage, when I work with all the technicians, because that's what I enjoy and I do, is to, you know, and the doctors, to allow them to make just minor changes, because you're not going to hurt anything. It's not like you're going to go from, you know, dramatic changes, but some minor changes, and evaluate and keep track of them to kind of learn how the animals, you know, adjust. And obviously you need technicians that want to be very attentive. As we get close to 3 o'clock, does anybody else have other questions that Kirsty could help with? You know, don't be shy. We can give you Kirsty's email address. Everybody should have my email address, but because these invites come from my email address, but feel free to, you know, connect. Part of my job with Elevation is to try to help connect all of the users so that you guys can talk to each other. Because I can give my suggestions and what I've learned, but as you all know, every situation is unique and different. And that's why I really enjoy having somebody on every month to chat with. And please, I want you guys to reach out and not ask me for answers, but say, hey, has any, you know, do you have any other customers, clients, users that have seen X, Y, and Z? And, you know, that's what we're trying to enable a little bit on Facebook, but I can also connect anybody via email if that would be helpful. We're all here to help each other. I think we can make things amazing as this whole issue of, especially the myofascial world, is constantly evolving.
I think we should definitely have a chat about another article for the publication I just wrote for. So if anybody want to reach out to Cindy, and she'll supply you with my email address if I can help you guys in any way.
Thank you,
Thanks for
Kirsty.
coming. Thank you.
I appreciate it. Have a good day, everybody.